just to be mindful of everybody's busy time. Good afternoon. My name is Victoria Lancy, and I'm the Rural Education Manager with Michigan Center for Rural Health, and will be helping facilitate this program. I would like to welcome everybody to today's Special Topics Grand Rounds on Meaningful Use and the Merit-Based Incentive Payment System in 2017, which is brought to you by the Cerner Corporation and the Michigan Center for Rural Health. Just a few reminders before we begin. If you're logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you're listening only through to the program via the audio number provided, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across your top, scroll down, find today's date, and there you will see the presentation, an attendance form, and an evaluation link. Attendance forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office if you would like to receive a certificate of attendance. An evaluation can be completed online. These forms must be completed within 2 weeks or by September 5th. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A component at the end of the program. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I'm pleased to introduce our speaker, Justin Kirkpatrick, a Community Works Regulatory Integration Architect at Cerner Corporation. Go ahead and take it away, Justin.
Sure. Thank you very much, Victoria, for the introduction. And welcome, everybody. As Victoria has indicated, we'll be talking about meaningful use and then the merit-based incentive payment system as well, kind of with an eye towards 2017 and 2018 reporting. So the agenda is pretty basic. It's just those two topics, and we will be kind of walking through those. As she said, save your questions till the end. We should have plenty of time to work through anything that you might have question-wise. So if you can jot those down and save them to the end, we will be sure to cover them. If we can't, I can touch base with you via email or anything else if whatever needs to be done to facilitate the answered questions. So sorry, having some technical difficulties. There we go. So starting off with meaningful use review, a review of the program. Meaningful use isn't necessarily new at this point. We've been kind of living this life for a while, but it is helpful to kind of start off with the basics of what is meaningful use. And to cover that, CMS, it was kind enough to kind of give us a definition of what they consider meaningful use to be. So as you can see here, they define it as using a certified electronic health record or an EHR to kind of hit those bullet points, the improve quality and safety and efficiency and reduce disparities of healthcare, engage patients and families in their care, improve care coordination, population and public health care that's provided, and then maintain privacy and security of patient health information. Kind of the stair steps that you see at the bottom align pretty closely with the stages of meaningful use that they've outlined from the beginning. In stage one, we're implementing EHRs, people are going live, we're capturing that data, we're figuring out the standards that we need to adhere to maintain and keep that data relevant and strong. Stage two, we move into, great, we're capturing the data, we're getting all of this data recorded. What do we do to make it more relevant and impactful to practices? And then in stage three, kind of as we progress down the meaningful use life cycle or timeline, we're gathering that data, we're capturing it, we're using it more powerfully within our own system. Now we want to share that data with other systems and make it more impactful to patients, allowing them to access that data, giving them some control over their own health data. So just the interoperability is kind of the key component of that as we move towards stage three. So again, specifically looking at meaningful use, who can participate? Obviously, hospitals and providers are kind of the two target audiences there. So kind of a little further defining that, for eligible hospitals, they can participate in both Medicare and Medicaid meaningful use programs because they are two separate programs. You can see the list of hospital types that can participate in each. Subsection D hospitals is the big call out on the Medicare side. CAH falls into that category. And then if you're in a Medicare Advantage hospital. For Medicaid, it's more or less the same, but you need to have that threshold met. So it's a 10% Medicaid patient volume threshold. Children's hospitals obviously fall into that category. But the big takeaway there is that Medicare hospitals can participate hospitals can participate in both sides of the program, which leads us to the eligible professional side, or as we'll talk about, eligible clinicians is kind of the rebrand of the eligible professional. Really for intents and purposes of Medicaid attestations, is all we're looking at for EPs at this point in the life cycle of meaningful use. Medicare has pretty much completely taken the meaningful use piece and incorporated into MIPS, which we'll look at kind of towards the latter half of this slide deck. But really, Medicaid is the only place that you're doing meaningful use as an eligible professional anymore. So there are just a few situations where a eligible clinician could participate in both programs, meaningful use and MIPS. So we kind of made this little flow chart of where do I fall or where do I fit in the equation. So you can see if I'm in a hospital, I'm still doing meaningful use, nothing's really changed. Likewise with critical access and kind of so on down the list. The one with the green arrow by it is calling out clinicians specifically, because there are some scenarios where a clinician could be in meaningful use and in MIPS. MIPS we'll talk about a little more, but the meaningful use piece of that with Medicaid really only applies if the provider has incentive dollars left to recoup from the Medicaid meaningful use incentive program. Since Medicaid has no penalties associated with it, you're really only participating in meaningful use insofar as you have incentive dollars left to recoup. If you've already recouped all of the incentive payments that are available to you as a Medicaid provider, then you don't necessarily need to participate in that meaningful use program for Medicaid. Because as we'll see, the targets are a little stricter for Medicaid providers in meaningful use. So in 2017 and 2018, these are the measures that we're looking at, and we'll kind of clarify the 2018 piece there on the next couple slides. But I'm not going to go into each one of these in really great detail. These are just the targets that we need to hit in order to kind of achieve the thresholds that they've put out for us. You'll notice that there's the top two are in red. Those were removed last November in the outpatient prospective payment system. So they're kind of sneaking meaningful use bills into other pieces of legislation now. So in the OPPS rule, they removed CPOE. So as a attestation measure, it's still something that they're expecting providers to do, that we've proved that we can do CPOE well and report on it well, and they've got lots of good data indicating that. So it's removed as a reporting measurement for meaningful use, not necessarily a don't do CPOE anymore call out, but you're no longer attesting to it. It is still part of your cert. It is still part of using the EMR in a meaningful way. It's just not something we attest to anymore. Likewise, with CDS, which is clinical decision support, any EMR, more or less, is going to have those baked into the software that you're using. They've seen us report on this for quite a while now. It's what they call a topped-out measure like CPOE. They just no longer want us to report that data. It's still something that could potentially come up in an audit. So it is something that we still recommend you have kind of proof that it's in your system and that you are doing it. But it's not something that, as you're attesting, will say, yes, we're doing CDS and kind of check that box. So after you move past those two that were kind of quote unquote retired by CMS in that rule, we come to patient education. The threshold there is 10%. So for 10% of the patients that you see, you would be providing education to that patient. MedRec, 50% of the patients that you would be getting med reconciliation performed on them. View, download, and transmit has two pieces to that measure. Measure one is providing that patient access to your patient portal. And then measure number two is that patient actually logging in and touching that data or using that data in some way. Measure two is obviously kind of outside of your hands. That's why it's been reduced to one patient. So as long as one person is doing that during the reporting period, you can consider that as being met for the hospital. The 50% mark is a little more challenging where you're actually offering that access to that patient. Summary of care at transition is sending a CCD document for the patient. It has to be sent electronically, and it's a 10% threshold. Security is just performing a security risk assessment. It's a yes or no objective. We've been doing that for meaningful use for a long time. It doesn't change all that often the requirements of what's included in that risk assessment. It's pretty par for the course, I guess, at this point. It's nothing new about it. Number 8, e-prescribe with drug formulary checking. Again, 10% of the prescriptions that you write should be sent electronically through some sort of e-prescribing service. And then number 9, public health submission. So you're submitting 3 of those 4 options as a hospital to some sort of reporting body, whether that's the state or some other registry. For most hospitals, immunizations, reportable lab, and syndromic surveillance, as long as your state accepts it, which I believe Michigan does. All 3 of those, kind of the easier options for the hospital. It gets a little grayer when we get to providers. Those kind of at face value, those are what we're looking at testing in 2017 and 2018. So I did mention that the Medicaid provider numbers look a little different, and they do. This is the provider targets for those EPs who still have Medicaid incentive dollars. So if they're still trying to finish out that Medicaid incentive program for meaningful use, these are the targets for them. Most notably, the numbers are all higher. I won't run through the whole list again, but the numbers are harder to hit. And they have not retired CPOE or CDS for Medicaid providers, so you would still need to attest on those 2 pieces of information. So again, just a little harder targets to hit for the Medicaid program. So just recently, the inpatient prospective payment system, I mentioned the OPPS, now we're looking at the IPPS, was released, I think it was August 2nd, they released that final rule there. And that made some changes to what we're expecting to be required of us for meaningful use stage 3 and for the IQR if you're participating in inpatient quality reporting. So for meaningful use, essentially what that distills down to is for all providers, that's a hospital, critical access hospital, or any Medicaid EPs, you have a 90-day reporting period in 2018. So again, they keep putting it out that, we'll have a full year, and then they always seem to dial it back to 90 days. So once again, they've done that for next year. So we have a 90-day reporting period in 2018 as well as 2017. They also finalized that you can use 2014 CERT or 2015 CERT for 2018 as well as 2017. So essentially what that means is before this rule was finalized, we expected to be on 2015 CERT required and on meaningful use stage 3, January 1st, 2018. With this final rule passing, they gave us the flexibility of doing 2014 CERT or 2015 CERT. So we could essentially do meaningful use stage 2, or the modified stage 2 that we're kind of living in now and doing right now, again next year for 90 days. Or if the stars align and we are good to go with meaningful use stage 3, you feel comfortable with your numbers all look good for those measures, you could potentially do meaningful use stage 3 next year as well if you wanted to. So it really gives you flexibility there in what you're reporting. For the IQR, some really, really big changes there actually. And so just briefly touching on them, they allow that CERT flexibility as well. in 2018, but the big one is the second bullet, where they require 4 ECQMs to be submitted electronically in 2017 and 2018 over 1 quarter. I say that's a big change because currently, or before this final rule, it was 8 ECQMs for the whole year. So it's quite a big dial back, and that carries on into 2018 as well. So 4 ECQMs electronically submitted from 1 quarter. It's a pretty big concession on what they were asking us to do before. So advance through here real quick. So the staging for meaningful use, again, a little bit of this is historical. You can see in 2014, we had that 2014 CERT requirement. CERT is just the base code level that your system needs to live up to. So your EMR would need to live up to in order to be able to attest to modified stage 2 or meaningful use stage 2. We've been on 2014, Cerner has been on 2014 CERT since 2014. I forget the exact code level, but it's been a while. We're just now going to the 2015 CERT. And the 2015 CERT is the requirement for stage 3. So you can see in that last blue arrow to the right, we were expecting 2015 CERT to be the hard requirement there. With the IPPS rule, they gave us that flex, so we could still kind of keep it the same as we were this year, and you could pick and choose if you wanted to do modified stage 2 or stage 3 next year. So then the 2015 CERT wouldn't be a hard requirement until 2019 when they do move us to stage 3. So to kind of wrap up the meaningful use portion of the slides before we get to the new program on the block, I just wanted to include some links to all the rules, the various rules and regulations for meaningful use. So you can see we've got all the meaningful use rules in the top portion, and then the certification rules in the bottom portion. The callouts for CMS and the Office of National Coordinator there are kind of important because CMS is the body that gives us the rule or the meaningful use rule kind of in the top portion. And then the Office of the National Coordinator is who comes up with the certification standards or the CERT level requirements that the EMRs have to incorporate into their system to be able to be considered a meaningful use compliant EMR. So it's just 2 governing bodies that produce these varied documents that kind of outline what we're required to do for meaningful use. So if you ever need some light reading, you can peruse these documents at your leisure. So with that said, we will move to the merit-based incentive payment system. And I wanted to kind of move through meaningful use a little bit faster because it's been around for a while. Potentially you've been attesting to it for 5 or so years now at this point. It's had slight variations, but merit-based incentive payment system is net new for this year, essentially. It's kind of an amalgam of several programs that we'll look at on the next couple slides. So I'm going to go ahead and advance through all this too, because I think it's easier to see the whole picture all at once. So, Medicare Access and CHIP Reauthorization Act at the top is the rule or the piece of legislation that spurred the Quality Payment Program. The Quality Payment Program, or the QPP, is split into 2 separate pieces. There's MIPS, or the Merit-Based Incentive Payment System, and then there, on the other side, there's the Advanced APMs. We're going to be focusing on the MIPS side, so we'll just casually talk about the Advanced APM side on this. But more or less, as a eligible clinician, you would fall into one side of the QPP or the other. On the MIPS side, it's, as I said, kind of a mashup of several programs that you were likely participating in before. So quality, or what you might think of as PQRS. Advancing Care Information is their rebranding, kind of the new name of meaningful use within MIPS. And then improvement activities is something net new that we've never done before. So we'll talk a little bit more about that in a few slides. Cost performance is the 4th piece under MIPS. It's not actually being brought into the MIPS calculations until 2019 now. The value-based modifier is probably the closest thing that adheres to what cost performance would be. It's kind of replacing that value-based modifier program. You're not attesting to it in 2017 or 2018 now, potentially. After the final rule comes out in November, we'll know for sure. But for sure not attesting to it in 2017. On the advanced APM side, if you fall outside of the MIPS piece, there's a couple requirements just to be in an alternate payment model that they consider to be kind of quote unquote advanced. It has to use CERT, so it has to be 2014 or 2015 CERT compliant. You have to have some kind of payment based on quality measures, and then you have to share financial risks or be in some kind of medical home model with that entity that is the advanced APM. CMS has outlined, I think, only like 6 APMs for this year, or advanced APMs, excuse me. Like CPC Plus is counted as one. There's several oncology specific payment models that are included in that, but it's a very limited scope at this point. Like I said, there's only 6 out of the many varieties of APMs. Track 2 and Track 3 ACOs potentially qualify for that as well. So it's just a more limited view. Most folks are going to fall into the MIPS side of the equation, hence why we're going to kind of focus on that piece. But if you kind of read the writing on the wall, the advanced APM side is where CMS wants us to go in the future. You can kind of see that by that there's no penalties associated with advanced APM. There's only potential for incentive. Just kind of an eye towards the future. I think more people are going to fall towards that advanced APM side as we kind of progress. So then who is impacted by MIPS? So as you can see here, again, we rebrand eligible providers into eligible clinicians, but it's any eligible clinician who bills Medicare Part B services must participate in MIPS. So the reason that they've rebranded providers to clinicians is because they're really broadening the scope of who participates in this program. So you can see in 2017, we've got kind of the normal meaningful use suspects, physicians, but we're also expanding that to nurse practitioners, PAs, CRNAs, and then some other select nurse specialties included in that as well. As we move forward in 2019, it's proposed to expand even further to kind of encompass more people that bill Part B services, Medicare Part B services. Some of the examples that they gave us in the rule were social workers, dietitians, audiologists, but it's really going to become much broader as we move forward through the program. See in the white box, one quick little clarification. So if you are part of a RHC or a FQHC, so a rural health clinic or a federally qualified health center, you bill under those billing paradigms. You don't bill the PFS, the physician fee schedule, and so you might fall out of the MIPS equation there based on that billing type. But you do want to kind of double check if you are an eligible clinician who does practice in one of those designated billing type kind of paradigms, but you still pass Part B billing through the PFS occasionally, you might still need to attest to MIPS. So just be really thorough in kind of investigating where your requirements lie based on your billings. So we talked about who's included in MIPS. Now we'll talk about how to get out of MIPS. Currently, there's these 3 ways. On the far left, we've got low volume threshold. So to qualify for the low volume threshold, if during that performance year, so the totality of 2017, you bill fewer than $30,000 or have fewer than 100 Part B Medicare beneficiaries, you could potentially claim that low volume exclusion and be removed from MIPS and not have to attest to MIPS. The second way is if you're a newly enrolled EC, so you're a brand new provider, you're right out of school, you've never billed Medicare before, whatever the scenario is. If you have a brand new PCOS number and you've never billed Medicare before, you can be removed for that first year of your billing practice. So you kind of get a pass on that initial year. Subsequent years, if you don't hit the low volume, kind of be expected to be included in MIPS. And then the third and final way on the far right is if, as we looked at the QPP program before, if you fall outside of the MIPS and fall onto the advanced APM side, you could be excluded from MIPS in that way. So MIPS reporting. There's two ways currently to report to MIPS. You can report as a group, or you can report as an individual. So a group by 10 or an individual 10/NPI. Couple things to consider there. If you submit as a group for one category, you have to submit as a group for all. So if you're part of a small practice somewhere and you all bill under 110, and if you bill as a group for one out of the 5 providers in that 10, or whatever the scenario is, then you need to submit as a group for all categories within MIPS. So that would be the 3 that we looked at: advancing care information, quality, and improvement activities. So if you do group one way, which probably quality is the best example, because there's so many ways to submit quality. If you submit quality as a group through an ACO or some other scenario where you're required to group submit data for quality, then you would need to group submit for everything. And then reporting mechanisms need to be the same per category as well. And again, quality is probably the best option there because there's just so many ways to submit quality, as we'll see. If you submit via the web interface, the CMS web interface, for one person, then the whole group needs to submit through that same mechanism. So we have a couple just kind of walk through examples of the MIPS reporting. So you can see here, Dr. Smith, our generic provider example, bills Medicare Part B services under 2 unique 10s. So she has her individual 10 on the left, where she bills Part B services in the clinic, and then she also rounds on the weekends or through the ED or whatever the scenario is at the hospital on the right under a totally separate 10, and she bills Part B services there. So she's got these 2 distinct avenues of Medicare Part B billing. So again, on the left, where in her clinic billings, she must meet all MIPS requirements, which we'll take a look at in a moment, and then report her data individually to CMS for services provided under that 10. And then under the hospital can attest on her behalf as under a group for that 10. So the hospital would be aggregating that data and submitting all that data for the group of providers under that 10. So again, continuing down this example, we'll just say that on the clinic side, she fails to submit to MIPS, reporting individually through the clinic in 2017. So she would see a 4% reduction in her 2019 Medicare Part B billings based on missing that attestation in 2017. So like Meaningful Use, it's a 2-year look back on if you did or didn't meet the requirements for MIPS. On the other hand, the hospital does submit successfully under their group. So her billings there are not going to be affected by that penalty. They would instead be a 0 to 4% increase based on where they fall in the MIPS equation, which again we'll look at when we talk about the composite scores for MIPS. So again, just kind of that idea of up to a 4% reduction and up to a 4% increase in your billings, depending on where you fall in the paradigm. If you don't submit anything, you've kind of already automatically hit that minus 4% reduction. So 2017 being the first year for MIPS, it's a little bit unique in how we can attest to MIPS. So you can see on the breakout here, we've got some options that CMS has afforded us, kind of the quote-unquote pick your pace route. So really for 2017, there's no reason anyone should fall into that far left blue box, which is you just don't do anything. you don't do any submissions of any kind to MIPS, you automatically get that 4% negative adjustment in 2019 based on failing the 2017 reporting year. And I say that no one should fall into that box because we have the box right next to it to the right, which is just test the program. Within the test, we do one piece of the 3 pieces that CMS is asking us for. So we do quality submissions, we do ACI submission, or we do improvement activity submission. As long as we do one of those 3 things, then we have satisfied the test requirement, and it would be just a net neutral outcome for us. We wouldn't get any penalties, but we also wouldn't get any incentives either. There's a couple call-outs on things to watch out for the test. So for ACI is really the big one. You need to hit all the base measures for ACI in order to be considered, having submitted that test data. And we'll talk about base measures in a few slides. Partial or full submission is the next option. That's where you do 90 days up to the full year, so 90 days minimum, up to the full year reporting, just as they've asked for in the rule. And you report on all 3 measures, so quality, ACI, and improvement activities. Depending on where you fall on that composite score, you're eligible for that 0 to 4% incentive at that point. One kind of thing to keep in mind there is really, weigh how your data looks, 90 days versus full year, or some mix match in between. I say that because if hospital or provider group A and provider group B, provider group A does a full year's reporting and say scores a 75 for their composite, and provider group B does a 90 days, but they score a 95 for their composite score. Provider group B's composite score is larger than provider group A's, even though they only did 90 days and provider group A did a full year. They would still potentially get a better incentive outcome than provider group A, even though their time, like their reporting period, was much smaller. So just kind of something to keep in mind there, really weigh your data options on what your data looks like. And then finally, again, if you're doing an advanced APM, you're outside of MIPS, you're potentially getting that 5% increase to your billings if you meet certain criteria within that program. And then the little arrow at the bottom just kind of outlines the pick your pace option. 90 days minimum between January 1st and December 31st up to the full year is the performance period. The portal opens January 2nd, and then it closes on March 31st. So we have a little bit more time than we were used to with Meaningful Use to kind of finish those submissions. Gives us a little more time to dig through the data really and see where our numbers look best. So we kind of alluded to MIPS scoring a few times. You can see here just kind of a graphical representation of that scoring. Quality measures, or PQRS, it makes up the biggest piece at 60%. So it's a pretty large chunk of what we're looking at this year. Advancing care information, or meaningful use, is 25%. So a smaller portion, but still a meaningful piece of that pie. And then improvement activities is 15% of the overall composite score. Essentially, you get a score for each one of those pieces. So quality measures, you get a score. ACI, you get a score. Improvement activities, you get a score. All those combine to make your composite score. Where you fall on your composite score as compared to everyone else that participates in MIPS determines your incentive or your outcome within the MIPS program. So the next few slides, we will kind of run through those individual pieces, those 3 pieces, and kind of talk a little bit about how they're scored. This is definitely not in depth. There's a lot of ins and outs on these scores, but we're just trying to give you a good base degree of knowledge here. So again, quality is weighed at 60% of your total composite score in 2017. You submit your quality data based on kind of the outlined table there. So if you have 15 or fewer ECs that you're submitting the data on, you're submitting 6 quality measures. There's no population-based measures. and then you have 60 points possible. So essentially each one of those measures is worth 10 points. If you have more than 15 eligible clinicians in your group, you have the 6 measures again, but then you also have one additional population-based measure that CMS will pull out for you. You can see at the bottom what is the population-based measure, just kind of calling out what measure they are pulling out for that population-based. So it's the 30-day all-cause hospital readmission. You don't have to submit anything for that, as it says in blue. They pull that from your billings. So it's data that CMS aggregates for you. There's no additional submission requirement on your part. But if you do fall in that middle band of the table, it's 70 points possible for the quality score. And then finally, if you're submitting via the web interface, the CMS web interface, there are 14 measures, 15 including the population-based measure, 14 measures that you must submit data for in order to get your quality score. And they actually have those outlined of what those 14 measures are. You can see that there's 15 measures, so that equates to 150 points possible. If you're in an ACO, track 1, and submitting quality through that ACO, you will be submitting through the CMS web interface option. The ACOs are required to submit quality through that option. And we'll look at options in a couple slides because there's quite a few for quality submissions. So just some kind of generic examples of how you get a score out of 10 points for each one of those quality measures. You can see here some examples of quality measures in the measure name section. So the top one being falls, screening for future fall risk. Depending on your performance rate, which is kind of what's outlined in those decile columns, if you have a performance rate of, let's say, 65%, you would look in the decile range columns and find 65% that falls squarely within decile 7. So you would know you have about 7.5 points possible out of 10 at that point. There are some that are inverse, kind of scrolling down in that table to the diabetes, hemoglobin, A1C, poor control. So that is a inverse measure, meaning that the lower your performance score, the higher your decile score. So you can see the same example. If you got a 60% there, you would be at 3 points essentially. Actually 0 points, I think, because you're outside of the decile range. It starts at 3 points. But the lower your score, so if you scored a 5, performance rate, 5% performance rate, you would be in that decile 8 band and get around 8 points for that measure. So it's really kind of weighing your options on how you submit and seeing where your numbers look the best. So again, I mentioned that there are lots of options for how you submit this data to CMS. This slide will kind of be the proof of that. So you can see in the bullets on the left, CMS has given us about, I think it's 271 measures available, which providers can report to via a plethora of methods. The link there will take you to a list of all those measures. Things to consider is cost associated with these reporting methods. There's always going to be some kind of a cost associated with submitting this data. Just kind of weighing where your numbers look best and whatever cost is associated with that, and just making sure you make the right decision for your group or your organization. And again, the provider mix is a lot of so just for example, EMRs, so a Cerner, an Epic, and Allscripts, whoever your EHR vendor is, we can only attest to a given number of those 270. I think it's 53 of the 270 that vendors can even attest to. Actually, it's 51, I'm sorry. So out of those 271, we only have the option to submit 51. And those 51 are kind of honed in on the ambulatory space, so like clinic visits. So if you are a surgeon, you're probably not going to have a lot of data that's pulling into those 51 measures, and you'd probably want to look outside of the 51 into the broader 270 to try to find some that fit for you. But that'll mean that you'll need to find some kind of other reporting method as well. So you can see in the little boxes, we've got group and individual reporting options outlined. And like I said, each one is probably going to have some kind of a cost associated with it. So just kind of weighing those options as well on what's easiest for you, where you have the best numbers, and what might be the most efficient cost-wise for you. So ACI, again, meaningful use. When we say ACI, it's weighted at 25% of your composite score in 2017. You have to utilize CERT in order to meet the requirement for ACI. So 2014 or 2015, as we kind of discussed, or some combination of those two. You need to reach 100 points possible, 100 total points out of ACI in order to get your 25% score. So to get the full 25% of the composite, you need to achieve 100 points out of 155 possible. If you're doing 2014 CERT, there are 4 required measures in 2017. If you're doing 2015 CERT or Stage 3, there are 5 base measures, which we'll look at on the next slide. All other measures outside of those base measures are factored into performance scores, which I think will make a little more sense when we look at the next slide as well. There are some bonus point options available in 2017 that CMS has given us, which again, I think we'll run through and make a little clearer on the next slide. So base measures, as you can see on the left, you have to do all of these things or you get no ACI score, essentially. You have to satisfy every one of these 4 base measures, 5 if you're doing Stage 3, 2015 CERT next year or this year. So the first one is do your security risk assessment. As long as you do that, you've met that. It's a yes, no, just answer yes and you're in good shape there. The next 3 are you have to have at least 1 in the numerator in order to get credit. Doesn't matter how many are in your denominator, just do it 1 time, 1 numerator, and you've met that base score requirement. So 1 e-prescribe or 1 e-prescription sent, 1 successful patient access encounter, sending an electronic transition of care 1 time. As long as you do those 3 pieces 1 time in the numerator, then you've met the base measure and you've kind of got 50 points out of your 100 that you need. So if you've been paying attention to meaningful use at all in the last few years, the base measure should be really easy for you to score. Shouldn't be a high hurdle to meet, but you do have to meet those requirements in order to get any kind of points for ACI. So moving on from base, we've met all those measures. I guess request, I'll mention the last one for 2015 certs, request to accept patient care records. So incorporating a transition of care document at least 1 time, 1 in the numerator in order to meet that. So as long as you meet base measures, get half your score. The middle column, the 90 points for performance measures, you need to get your other 50 points from there essentially, or from the bonus in the last column, which we'll look at. These are the measures that we looked at earlier. Provide patient access, so VDT1, VDT2, patient-specific education, secure messaging, health information exchange, MedRec, and submitting data to an immunization registry. You'll notice that a couple of them are double weighted for 2017, VDT1 and transition of care, which are also base measure requirements. So just even more incentive to do well in those 2 because they're double weighted. Essentially, you need to get your other 50 points from that middle column or the bonus measure column. Bonus measures include doing some additional public health reporting. So if you're doing syndromic surveillance submissions to the state, that could be 5 bonus points. Report improvement activities using a CERT. So if you're doing an improvement activity that requires a CERT in order to achieve, you can get some bonus points there as well, 10 bonus points to be specific. Improvement activities. 15% of your composite score. They kind of designed these to reward clinicians for conducting activities that kind of hone in on that care coordination, engagement with the patient, and then also safety of the patient. CMS gave a list of 90 of these improvement activities. You need 40 points total in order to receive your max 15% of your composite score. They're broke down into 2 categories. So you've got medium, which is worth 10 points, or high, which is worth 20. There's a couple examples listed there. The list of 90 clearly defines them if they're a medium or a high. So when you're reviewing that list, it's pretty obvious what they consider them. The little asterisks there is kind of important. So if you're a practice of less than 15 clinicians, you can have those point values double weighted. So a medium in that category or in that instance would be worth 20 points instead of 10, and then a high category would be worth 40 points instead of 20. So one high category would kind of get you to the points that you need. And then the final bullet, which kind of outlines a couple other programs that are worth improvement activity credit within MIPS. So if you're participating in a patient-centered medical home, that could be 40 points. And if you're doing an alternate payment model, so if you're in an ACO, like a Track 1 ACO, just participating in that gets you 20 points as well. So kind of halfway towards that 40-point total. And then PCMH gets you all the way to that 40-point total. So I mentioned the list of 90, which you can see in the link there. Will take you out to that full list. The table that we're looking at is a list of activities that are worth bonus points for ACI. So I mentioned that you could do one of these activities and get 10 bonus points. This is a list of those activities. You can find them on the linked list just to kind of get more detail on them. But these are the names and then their weights and if they're worth bonus as well. So maybe a good place to start if you want to kind of solidify your ACI score and make sure you get that bonus point opportunity achieved. Maybe start on this list and find an activity that you're able to participate in or already doing a lot of the time and count that as one of your activities. I would say review that list though. Odds are you're already doing many of the things on the list. It's a pretty broad scope of things included on the list. And not all of them require an EMR to complete. Some of them can be done pen and paper or manually without using any kind of computer system. So we do have some proposed changes to run through really quickly, and I'm going to try and go through them relatively quickly so we have some time for questions. I know we're going a little slow. But we have the proposed rule. So the quality payment plan proposed rule came out a few months back. So you can see here the bullets kind of outlining what we're waiting on them to clarify and tell us how it is actually going to work later in the year. Typically comes out early November, so kind of like right before the end of the year. But as proposed in 2018, it would be a FlexShare for cert level in the QPP as well. So you could attest using 2014 or 2015 cert, aka under modified stage 2 or stage 3, depending on where your numbers look best or what you feel like will give you the best outcome. Just gives you some flexibility there if they put that through as proposed. ACI on the second bullet would be a 90-day reporting period. So meaningful use is ACI. So we would have a 90-day reporting period for that measures, all those measures within ACI. And that also kind of gives us some flexibility on cert, so we can hit 2015 cert after January 1st in that scenario, which is kind of interesting. 2015 cert requires API access at every instance for the provide patient access VDT2 measure within the performance period. So what that means is API is a application programming interface. It's wrapped up into cert. It's something that's required to be present in your EMR in order to meet 2015 cert. Basically what that's saying is that you need to offer that API to the patient at every encounter during the reporting or the performance period. API is, think of it as the logging into like HBO Go or some other tool portal on your cell phone. So if you have an HBO account, you can log into HBO Go from your cell phone. Similar idea, but with the patient portal in mind. So allowing patients to access their health data through some kind of an app on their smartphone. It's a little more complicated than that, but that's kind of the gist of what that API piece is asking us to be able to do. And then the final bullet there is it's proposed that ECs would receive bonus points for testing using 2015 cert for ACI in 2018. So kind of a carrot on the stick or a little reward for going to 2015 cert within MIPS next year, where you could get some bonus points there. So I'm not going to run through each one of these specifically, but just some compare and contrast requirements for each measure. So this one's quality specifically. You can see what the final rule in 2017 gave us, and then kind of how that's changing in 2018. And we've got a slide for each one of these. And just in the sake of time, we're going to kind of speed through these. So there's ACI was the previous one. This one's improvement activities. There's ACI. And that's the end. So I wanted to give us some time. We've got about 10 minutes. Victoria, do you typically unmute the phones for questions, or do you have a list of them that people have sent in, or just want to make sure
we just unmute all the lines, and then
okay.
So I'll unmute all the lines, and everybody can either ask their question verbally, or you can type it into the chat feature, and then I can read out the questions aloud. So everybody, you are now unmuted. So if you have a question, please feel free to ask your question now, or you can type it into the chat feature.
Don't be shy. Anything at all.
Questions, comments for our speaker?
I guess one thing is I will send a copy of this to Victoria so she can send it out to the group. So if you wanted the slide deck, you'll get a copy of it.
Okay, so, and I have posted the one that you sent me before. I did post it to our website already.
Yep. Good deal.
Everybody can get it. It's on our website, and I can resend it out to all the presenters or all the attendees as well. If you don't have any questions or comments, we can get off the line, or if you think of any questions for our presenter later, you can email me directly, and I can pass them along to our presenter, or you can fill them out on the evaluation, and I can send them to our presenter that way as well. Okay, looks like we don't have any questions right now. Thank you, Justin, for presenting. And if I get any questions via email or phone call, I will pass them along to you.
Yeah, thank you for having me. I know it's a lot of information to absorb, so I appreciate the opportunity to talk to you.
Okay, thank you. And thank you, everybody, for attending.
Thanks, everyone.